Good afternoon, everyone. I'm Debbie Nadsam. I'm the project director for the VCSQI SAN 2.0, which listeners are enrolled in. We are recording this session for posting on our website. We're very fortunate to have with us on many levels Dr. Jeffrey B. Rich today. He comes to us with a significant background in the cardiothoracic surgery specialty area, having been president of STS and in practice for several years in Virginia. Dr. Rich also ran Medicare for the last couple of years under the George W. Bush administration, and so is very familiar with CMS and the new world of physician payments that we're upon right now. Dr. Rich also was the author of the proposal that secured this CMS contract for VCSQI and now serves as our chief clinical advisor. He currently is the full-time department chair in the Heart and Vascular Institute of the Cleveland Clinic for operations and strategic directions. So, Dr. Rich, I want to turn it right over to you so we can get through your presentation.
Sure. Thanks, Debbie, for the nice introduction, and thank you all of you for coming on. So I thought then what I like to do in some of these presentations when we're talking about the new world of physician payments, I want to bring you back to the old world and walk you through how we got to where we are and why we got to where we are. So next slide, Debbie. Thanks. So Medicaid was established in 1965 by President Johnson, big social reform, biggest one, probably besides Social Security of that century. And what happened when it was established, there weren't many controls put into it. We thought it was a great idea and we established it, but we didn't realize that it could spin out of control pretty quickly. Next slide. The attempts at controlling costs are divided into areas and times. In the very first, and you might be astonished at this, but reasonable charge basis for physicians and hospitals was the norm. So if you submitted, go ahead, Deb. If you submitted the charge, that was reasonable, you'd get paid that, and there was no other control over that. And we then gravitated from the hospitals and physicians having reasonable charge basis in this 70s and 80s to hospitals becoming brought under DRGs and physicians being brought under the relative based or resource use system. The hospitals went on to medical severity DRGs with Medicare thinking that once they adjusted it for acuity of care, that there would be a fairer way of paying out for care for less complex versus more complex patients. Next. And finally, with physicians, we all know, and Kevin, you know very well what the SGR was. It was a formula because the RBRVS didn't work to control our costs. They developed the SGR, which was basically a budget neutral way of controlling physician costs. Physicians exceeded growth in our charges over the year greater than GDP. We were penalized, and it kept mounting and mounting and mounting. And every year, Congress put Band-Aids on it, and every year there were millions of complaints, and eventually needed to be adjusted. Next. In the era of 2000 and 2009, hospitals saw hospital value-based purchasing come into effect. I actually submitted all of that to Congress when I was there in 2008, except for the transformation curve. The hospitals on a continual basis undergo DRG adjustments. So every year, for instance, when I was there, we would do a look back provision to the DRG payments for the hospitals, and we would adjust them either upwards or downwards, and usually upwards because we wanted to be fair. It took us 2 years to get the data, but if we saw that costs were rising at Florida Hospital or Centera, then we would upward adjust the DRG payments. And for us, for physicians, SGR, that's what it was all about. And when I was at CMS, we introduced PQRS, which was a pay-for-performance model, so that we did it pay for reporting to begin with, and then we turned it into a pay-for-performance model. Next. Gabby? Yeah, thanks. So despite all of that, this is what happened to healthcare spending. It was exponential over the years. The green enters era when I was there, and I had the CBO, the Congressional Budget Office, give me estimates for what was going to happen. And this is what we were seeing, that we had uncontrolled spending, and despite all of the things that I just described to you, we couldn't really control spending. Next. And what really happened is the vertical line is where I entered the scene. I went to Rick Foster, who was the chief actuary of the United States, and I asked him what's the predicted modeling using conservative approaches for healthcare spending and healthcare financing, and this was pretty much it. 2017, the system was going to be flat broke. And so if you'll think about what we talked about now recently, and as we go through this, a lot of the healthcare reform initiatives were targeted, and they felt like they were coming fast and furious because we were trying to bend the cost curve and get away from bankruptcy this year. So next. What we did to the present, we still had hospital value-based purchasing, we still had the DRG adjustments, but then came along what we all love dearly to our hearts is the Affordable Care Act, and physicians were as much maligned by it as were hospitals. And so with the Affordable Care Act, put on controls at, creating value propositions. So your quality was going to be monitored, which was and paid for, and just realizing until the Affordable Care Act, and when I was there, we couldn't pay for quality. So if, Florida Hospital was doing cabbages at 0.5% and some other hospital was doing cabbage mortality at 20%, I had to pay them the same. So that was like egregious, and I lobbied Congress until they brought it forward in the Affordable Care Act. And then along came the Macra, which was after the Affordable Care Act, because we still had the problems under the Affordable Care Act with the SGR. So there had to be something done, and so that was the last piece of legislation that was done. Next, please. So Macra is the Medicare, that one, Medicare Access and Children's Health Insurance Plan Reauthorization Act, and it was done sort of politically correct because they put Macra onto CHIP because nobody was going to turn down the kids for their health care, and they were pretty savvy about this. So it happened before Macra. You could see here it was this SGR that we were living under for physicians. So if the overall physician costs exceeded target Medicare expenditures, then we had payment cuts. And each year Congress put Band-Aids on it until it got nauseating, not only for us, but for all of Congress. They really wanted to stop having to get into the chambers and argue this every year, but then it turned to every 6 months. Next. So what they came up with was under Macra, past Macra, repealed the SGR and developed the quality payment plan. And the quality payment plan has two arms. One are alternative payment models, which you see going to the left, which manage risk, and we'll talk more about that. And then MIPs, which manages penalties, the arm going to the right. Next. And one of the directives, and the true directive, and one of the reasons we're in this grant and we're talking to you, is that the legislation says that by 2018, next year, 50% of people are going to be in alternative payment models, and it expands beyond that until 2020, when 90% are going to be involved in alternative payment models. So the point of this grant is to try and teach everybody how to move themselves along that curve. Next. So this year is a transition year, and you pick your pace for participation, but your pace can be as simple as reporting one measure for one patient, and you'll avoid a negative 4% payment adjustment, as you see on the bottom. If you don't report one measure for one patient in this calendar year, you will get 4% downward adjustment to your payments, and you could get neutral or small payment adjustments all the way to modest payment adjustments, depending on how much you fully participate in this year. Next. So let's talk about MIPS, because I think MIPS is really the SGR on steroids. Next. PQRS, which we all knew when we were reporting measures, meaningful use electronic medical records, and the value-based modifier, which I began when I was there, and this is a physician adjustment modifier. It's all eliminated, and a single quality scoring system will be used. So we have 4 domains: quality improvement, EHR, clinical practice improvement activities like participation in the STS database, and then resource use. In 2017, the weighting of resource use will be 0, and the weighting of the other ones are listed there. Next. So within each domain, you will get a score, and the weighting of the domains will be applied, and you'll get a composite score, and the Secretary Price now will establish a threshold performance score, and you'll either get a positive or negative payment adjustment based on your performance relative to the target threshold. Next. The problem is that MIPS is a rob Peter to pay Paul mechanism. It's budget neutral. It's very much like the STR was. The STR was budget neutral. And with MIPS, they have added quality measures to what appears to be SGR. And you can have some pretty significant swings, as you see beginning in 2019, your payment, which is being tracked right now. So your scores are being adjudicated right now. Your payment in 2019 is either going to be up 4% or down 4% or some small fraction thereof, all the way to 2022, when you'll be competing with each other, and we'll be competing with each other for almost an 18% swing in payments. So the problem is, it's budget neutral, and some people one year are going to do really well, and some of the people who didn't do well the year before are going to improve their performance, and the people who did well the year before won't make it to the Super Bowl or to the World Series again. So it's a very destructive sort of payment system. And you'll see on the bottom, we're going to talk about alternative payment models, which is very much pro-payment for physicians in order to get us higher dollar amounts for innovative ways of delivering healthcare. Next. So in MIPS, there are clinicians, and I only put this up here because I wanted to show you that it's not just physicians, it's PAs, NPs, clinical nurse specialists, and certified registered anesthetists. That's going to expand next year, so there'll be a larger amount of people who are being affected by this, and even the Medicare Part B billing and the number of Medicare providers per patient year or per year are going to be adjusted. So I wouldn't pay too much attention to that. I just want to point out that clinicians is pretty broad. Next. So alternative payment models is where the government wants everybody to go. It's where this whole grant is trying to move us along so that we get ready for alternative payment models, which are written into legislation. And so it's not going to be something that won't happen. It's going to happen. Next. So there are new approaches. APMs are new approaches to paying for medical care. It's something that either the government could design or we could design as individual providers and figure out how we want to be measured and how we want to be paid and the penalties that we want to accrue or not accrue. And we'll talk a little bit about these, but Medicare shared savings programs, there are different tracks. Some are subject to MIPS and some are subject to the bonuses that we'll see. But next. So we can develop alternative payment models in partnership with us, or the government can partnership with us. And we can define what high quality and cost efficient care is. For instance, the American College of Surgery has submitted an alternative payment model plan to the Physician Technical Advisory Committee, the STS. I helped write an alternative payment plan for the STS, which is going to try and be looked at and see if we could get it approved. But what is important to note is that APMs and advanced APMs are a little bit different, and they're structurally a little bit different. But the advanced APMs, if you're in an advanced APM and you're successful, it's very much more meaningful to your bottom line. Next. Next. So advanced alternative payment models really, what happens with an advanced APM different than an APM is that there's two-sided risk. So with an APM, although you have an upside that's protected, you don't have a downside risk. So you're not at risk for losing any of your income. With advanced APMs, you go to two-sided risks, and the downside is a lot smaller than the upside. But the fact that you're willing to take downside risk and modulate your practice so that you can get into an advanced APM, and I'm sure most of the people that we talk to can get into that, but advanced APM gives you an immediate 5% bonus, not retractable. You're an advanced alternative payment model. And the other thing is that your annual updates, which are flat right now, but they go to 0.25% under MIPs, but you'll get 0.75% automatic increase every year under an advanced alternative payment model. So they're providing for really innovative people who want to take two-sided risk. It really is far better than MIPS and much better than just an alternative payment model. So this is the taxonomy for APMs. So category 1 is what we've been used to doing for the last 20 years. There's no link to quality and value. As I said, we couldn't pay for quality, we couldn't pay for value. Category 2 is, as it states, fee for service linked to quality and value. Pay for reporting was there, and rewards and penalties for performance. Category 3, these aren't hurricanes. Now I know some of you are in Florida right now. Category 3.
I was hoping you wouldn't mention all those categories again.
Yeah, I know. Every time I saw one, I mean, we did hurricanes in Virginia as well. So every time I saw it, I always had a chuckle. But it's based on the fee-for-service architecture. So let's just be perfectly clear. It's a massive system, the fee-for-service architecture. It's like everything that's underneath of an aircraft carrier, the engines and all that, and we're not going to change that. We're going to use the architecture, but we're going to create new alternative payment models based on it. So category 3A is what I said, where you could be an APM, but you only have upside gain sharing. Category 3B puts you into an upside gain sharing and a downside risk, where 3B you get higher reimbursements than 3A, at least on the upside. Category 4 is population-based payments. Next. So in summary, the quality payment program is really designed to move you away from MIPS towards APM specific rewards, and then to really an advanced APM. And we'll talk in a minute about how do you develop an advanced APM or how do you participate in one. But the bottom line is the bottom line. You get a 5% lump sum bonus for your entire book of business, and you get a higher annual update. Next. So that's just a re-summary of what I just said. You're excluded from MIPS, which is great. You get a 5% lump sum bonus, and you have a higher physician fee schedule update. Next. So this is some examples of advanced APMs that were developed by the government, by CMS. If you read through these, next generation ACO model may apply to people. Shared savings program on this call. Shared savings programs, tracks 2 and 3, maybe. A lot of it's, end-stage renal disease and primary care and the oncology model. But if you remember, we had this mandatory cabbage bundle, and I'm not sure, Kevin, if you guys were impacted by it or anybody else that we've been talking to, but it got put on hold. It got put on hold because there wasn't enough input from providers on the design of the model. I talked a little bit about bundle payment model design. So this could be a way to be an advanced alternative payment model once they put this back on the table, which is probably going to happen. And that's one of the things that we're trying to prepare everybody for through the grant. Is how do you participate as specialists? Because our grant is an SAN 2.0. The SAN, the first version, they were all primary care focused. I lobbied and other people lobbied to get specialty care SAN in there so that we can also participate in some of these bonuses that were being talked about. Next. So really where we're going, category 3-4 by the end of 2019. ACOs, you could be in an ACO, you could be in some of these other models here. but I would suspect that many of us as cardiac surgeons are going to likely either be in an ACO or in a bundle payment system once they reintroduce that. Next. So getting ready for Macra is really getting ready, working with Debbie and us, to get ready for Macra and trying to understand all these changes that are some of them which are pretty catastrophic going forward. And I wanted to, I mentioned bundles. I just wanted to discuss briefly what bundles are and, set the groundwork for you to understand what could be coming at you next. So a bundle in our traditional fee-for-service system, remember we get paid for each and every service. It's all siloed. The pathologists get it. We get a fee. The pulmonologists get it. The hospital gets it. Everybody sends in their bills and their charges. That's fee-for-service. Bundling for a particular episode, let's say a cabbage, it pulls together all of the providers, hospitals and physicians and the clinicians, and they pay a lump sum for everything that happens to that patient during an episode of care. And that is a little bit more complicated, when you're trying to do it from a financial modeling standpoint, particularly if you're not hospital employed and your independent practice is working within a hospital. Next. So did it work? So part of what, when I was there, I introduced the ACE bundling. It was acute care episode, it was cabbage, and it was joint replacement. It was a demonstration project. And the BCPI, the joint replacement, showed that bundles did decrease costs, and it did. Next slide. So the answer was yes, because everybody started working together to try and control costs. Next. And it did affect quality, because quality did improve as people started, working together more. And I'm sure, Kevin and others on this call understand how it is when you start working and talking to your colleagues in the hospital. Things do change a little bit. The culture changes a little bit. Next. So what's included in the bundle? So this is the tricky part. This is what killed the cabbage, the mandatory cabbage bundle. That was going to be our roadway to advanced alternative payment models. CMS, so let's just think about the cabbage. You walk in the door and you walk out of the door. That's your episode of care. But in a bundle, there's some pre-op window monitoring that goes on. And it could be from anywhere from 0 to 90 days, actually. So if you're taking care of a patient who had a hip fracture 60 days ago, you're going to be responsible for those costs, perhaps. And then the post period, you have to figure out how many patients or how many days you want to be covered. So the problem was, battery's about to die here, I'm sorry, is that we can, it's all about designing the bundle appropriately. You have to figure out how much risk you want to go at before the procedure and after the procedure. And with the cabbage mandatory bundle, they were going out 30 days before the procedure and 90 days after the procedure. They didn't get a lot of input from physicians and hospitals and other clinicians. So there was a big advocacy effort to stop that from happening. So that's why we're not seeing it, but it's back on the drawing board. And so we're going to probably be facing this in the next year. And there's a lot of other bundling going on. Next. Debbie, can you go on? So, I mean, as you think about it, there are some exclusions for bundles. So these would be the patients that would not be considered in the bundle. These were some of the discussions that were going on. The renal dialysis patient, you didn't want in the bundle. They're extraordinarily expensive. The tracheostomy patient means they've had significant respiratory failure before the operation, circulatory assist devices. Anyway, there is some reasonable thought processes going on about who to exclude and who to include in a bundle. Next. So in summary, bundles will be back. Next. No, go next. I must have knocked these out of slide. So just wanted to say in Macra, this is the summary of Macra. you really have to be careful about being in MIPS, because you can see at the top, you could have a 9% swing either way by 2022. On the APM side, if we move you along and teach you out, or help you move into the APM world, those are your positive upsides that you can see there. And I'm sorry for the slides being out of order, but the bundles will be back and we'll have to deal with those. I would suggest, learn more about APMs and let's see what develops. If in the meantime, you can develop your own advanced alternative payment model, which the American College of Surgery is doing, the STS is doing, so that we can take the benefit of these bonuses that are going to be happening right away. Because it looks like 2019, but you're actually being tracked this year. Your payment occurs in 2019, but your tracking is happening right now. So I'll leave it at that and open it up for discussion. Thank you.
Thank you, Dr. Rich. Sorry for that delay in the one slide. My battery was running low and I had to run and plug my computer in. If anyone has any questions, feel free to unmute yourself, or if you can find the chat box. Eddie, has anyone submitted some chats? It looks like it.
We just got a chat from Steve. Go ahead, Steve.
Yeah, Jeff?
Yes?
Yeah, did someone have a question there, or is the floor open, or?
The floor is open. Go ahead. Go ahead.
Okay.
Tim.
Yeah, great presentation as always. We just can't hear this stuff enough to begin to absorb it and understand it. One of the things that Steve Dixon, our administrator, and I've gone over, and I think we've talked a little bit about it with the STS database, is because you mentioned PAs and assistants in surgery and how that's incorporated into the MIPS, and so whether it's a positive or a negative in any particular year. And some of that is not tracked in the database, because I understand that the STS database will be kind of the foundation of the information that's passed on. Is that correct?
Yes. Yes.
So
when you look under MIPS, if you're now talking about MIPS, there's a library of measures, and there are probably 12 measures under cardiothoracic surgery, and I think 8 of them are coming right out of the STS database. So you get to select your measures.
So, and Steve, if you want to pitch in here, but we looked at how we would be tracking, and we're trying to go back and how we can accumulate the tracking with assistants at surgery, because in our particular practice we use PAs. I know some of the other practices use physicians. How do we account for those people, because some of them will fall under the floor, if you will, of the MIPS criteria. How would we approach some of that?
This is Steve Dixon. If I could jump in, go ahead, Dr. Rick.
No, go ahead.
Yeah, if I could jump in. One of the things that we have found through working with the MIPS, Debbie and I looked into, is that since the STS database only allows individual practitioner reporting, it doesn't allow group reporting. So if you're a group of private practice cardiac surgeons that are reporting through the STS database, that is only going to allow individual reporting. So under that scenario, for our PAs, we will be able to report under the old PQRS, some of the old PQRS quality measures. So we will do that just to report a few measures to get them, quote, reported, so they won't get the 4% cut. In 2017, based on the Medicare guidelines, I think it's $50,000 or 200 patients or somewhere in that ballpark. Debbie, you can correct me on that. It only affected a few of our PAs, but the change next year in 2018 is going to increase the Medicare payments for the NPPs to, I think, $100,000 and maybe 200 patients or so. So that's going to probably knock out a lot of NPPs based on the payment that they would be receiving. So I don't see moving past 2017 as a big problem with many of the providers that have MPPs that are providing assistance at surgeries. However, the one part that I can't answer and have no visibility of are those facilities that use, that may have a academic program where residents are assisting at surgery or other physicians may assist at surgery. I don't know if the STS database captures assistance at surgery if it's performed by a surgeon. So that might be something that would reduce a denominator in some kind of statistical analysis or something that is going on within the MIPs for those that are participating within MIPs.
Right.
So I guess, back to the original question, then Jeff, is that with assistance at surgery, particularly with the PAs, because you mentioned it encompasses not only the surgeon, are we accountable to try to track that, or what would be your suggestion with some of those circumstances?
So I don't know if you are billing for your assistance at surgery or not, but remember, we're under a 90-day global. So like, if the PA is helping me and he's employed by me or she's employed by me, it's not a billable event. So that doesn't even fall under the MIPS thing. But we're already talking about elimination of the 90-day global to go to a 0-day global. So it would be more functional. It would be like the cardiologist when they do a cath or they do a PCI, every day that they see the patient, they submit an E&M code, whereas we don't, because we're under a bundle. And or a global, I should say global. I don't want to confuse it, but global. So no, if they're not billing, if it's not a billable event and you're not billing for those assistants, you have no responsibility for them, and they would not be tracked in terms of the quality metrics. The program would be tracked, and I think that's one of the problems is that I've talked to CMS about is that this has to be. We're talking about under a TIN, a taxpayer ID number. So your group, Kevin and Steve, you all have the same TIN, and so that's how you're going to be monitored, and that's how they do it within the ACO, the metrics.
Okay.
In ACO. So I know, Steve, as you said, it drilled down to individual physicians, but when you're under the same taxpayer ID number, it gets aggregated.
Okay. Oh, so then they'll be under that same umbrella then.
Yeah, everybody will be under the same TIN. So like with your group, or say we're in a hospital with this grant and there are 4 groups there that all have different TINs, they would be monitored differently.
Okay. Okay.
Dr. Rich,
great presentation as always.
Dr. Rich, this is Debbie. I wonder if you might speak to other types of registries that, because I know for sure one of our practices, dermatology, is listening, and others may listen to the recording. How might they get data submitted through registries, and where can they find measures?
So they have to apply to CMS and become a qualified data registry. And
A registry has to.
Yes, the registry has to. So like the STS had to do that. We had to do that years ago. NCDR does that. You submit all your information, and then there's probably 32. Last time I counted, there were 32 registries that were considered qualified registries, so that they could use the registry to report data.
Okay. I'm wondering, Terry, do you know if there's a dermatology one that you're practicing?
I do believe the AAD has a registry through it. I know that we used that last year, and this year it just seemed to become more difficult and really unorganized. And that's why Dr. P was going to try and report through the billing as opposed to through a registry.
Okay. And
yeah,
so,
go ahead.
Go ahead.
No, through called CMSO. That's where you go, and that's where the chief medical officer of CMS sits, and they're the ones who used to adjudicate all the registries. They'd look at the qualifications, the infrastructure, the measures that you're reporting, and then if you get qualified as a registry, you were able to report under PQRS with the registry, and it'll be the same for MIPS. It'll be the same for MIPS. Alternatively, you could decide to report as a practice individual practice, your own set of measures that you choose. And there is some choice here, and as I said, there's a library of measures that they put out that are qualified to be reported on the MIPS. Some of them are quite simple. I mean, let's say you have a multi-specialty group, and you don't really want to be held accountable. The dermatologists don't want to be held accountable to the cardiac surgeons if those are the measures you pick, and vice versa. You could pick generic measures like tobacco cessation, or somebody needs to answer their phone. Tobacco cessation, or patient and family engagement measures that are quite different and are cross-cutting across the whole spectrum of multi-specialty group.
Right. Thank you.
Anything else that came in through the chat box, Eddie?
Conference call, so I'll call you. I'll back. Thanks.
Yeah, Debbie, I have one question that sort of continued to elude me ever since I started working on that. This is Steve Dixon, and that is, we've got a range in 2019 from our 2017 reporting. We've got a range of a plus or minus 4% calculation as far as our payments, and is there a tool that we can use to estimate whether we're going to get 3.5%, 2.5%, or whatever? Because what I'm trying to do now is I'm looking at the quality measures that we're going to reporting. I'm looking at the improvement activity measures we're going to report. I'm going to be looking at the technology part that we'll be reporting. And I'm trying to do the math to figure out whether we're going to get a 4% or 2.5% or so forth. I don't know if that's even feasible to do, but is there a tool that is and can be used to calculate that?
Unfortunately, not that I'm aware of, because the tool is dependent on the data, and the data won't be out there until 2019. So you can't do it online. I mean, you can't do it real time, but in 2019, you'll be able to see how you stacked up against other performance measures by other providers. But there's no tool to calculate. I mean, I would just say perform as best as you can, and the chips will fall the right way for you.
Correct, and that's what we're doing.
Eddie, are you still on?
Yeah.
Wasn't there a QIN who had created a MIPS evaluator tool?
Yes, I was going to mention that there are several MIPS calculators out there that are essentially spreadsheets that you can enter your data into, and that will rank your program's quality metrics against the deciles, the estimated CMS deciles for each measure, and that will produce an estimated MIPS score for your practice. The only thing is that only gives you the MIPS score. That doesn't actually give you the percentage of reimbursement. As Dr. Rich mentioned, it's a budget neutral program, so the percentage reimbursement will depend on all the other programs' MIPS scores across the country as well. So you won't know necessarily where you line up with regards to all the other centers. Okay. So again, probably the best thing to do is just try to maximize your performance in your selected quality metrics.
We can get that tool though and make it available. That one that was it Great Lakes? The
Lake Superior Quinn QIO had a pretty good,
one of the Quins that we've spoken with.
Calculator.
Okay.
One other question again, Steve Dixon. Do practices have to have an EHR in order to participate in an APM?
That is debatable and being debated right now. I think that they realize that, like, for instance, in specialty practices like cardiac surgery, and your practice, and even my old practice, we didn't have EHR because when the EHR rolled out, it was very expensive. It was, probably $50,000 per member per practicing clinician, and the government was supporting practices to adopt it, but if you didn't do, if you did less than 10% of your practice as an E&M biller, you couldn't qualify for the bonus. So a lot of cardiac surgical practices, mine, yours, didn't even adopt the HRs because it was so financially hard to do so. So they're recognizing that they made a mistake.
Correct. And we were exempted from the penalties.
Right. But the problem, not the problem, yeah, it is a problem. You were exempted from having to adopt it. You were exempted from the penalties, but there was a transitional phase. So over a period of 3 or 4 years, the exemptions went away and the penalties went up. And all of a sudden you're looking at the penalties again. So it's been kind of a contentious issue that everybody's been trying to advocate for with CMS and HHS to make them realize that they stumble around this, making this requirement that 10%, more than 10% of your practice was E&M billing, when that cardiac surgeons are doing all procedural based billing.
Right.
And although we go and see patients in our office, the amount that we charge, for a CABG or an AVR or something far exceeds what we can get for an E&M office visit.
Is there going to be a data call or an information call for input to the CABG bundle initiative again? We participated, Dr. Akala and our group participated in the bundle payment program, Model 4, for the last, I guess, for about 2.5, 3 years. And we did see some decrease in the cost of care, but it was an onerous program. And I like the fact that you brought up, Dr. Rich, the debate on the pre-admission timeline, the episode of care, how long that's going to be, what are we going to define as an episode of care. So is there going to be an input period again for the CABG bundle program?
Yes. That's why they put it on hold, and everybody lobbied and advocated for having a further input period. I'm working with Acumen, which is a consulting company, and CMS about how to define this better. Like not only what do you exclude in terms of the diagnoses that we have, tracheostomy and renal failure, but what are the specific revenue codes that are attributable to a CABG, even if it occurs 3 days before or 90 days after. If you're have a CABG and you go home and as an elderly person and they fall and fracture their hip,
right?
That's probably not related to the CABG, right? So you have cardiovascular related revenue codes. So there's a lot of system logic being developed, for groupers to try and figure this out.
Okay.
And it was my feeling it was a little bit premature to push it as hard as they did early on, because we didn't have the groupers ready, for prime time.
Well, it's complex, and it's even more complex getting Medicare involved and getting their systems also set up, their common database file and so forth. So it's a complex system.
It created somewhat of a complex accounting circumstances just from our perspective to try and get paid by CMS, then the hospital got paid, then we'd have to reimburse CMS, and it was somewhat of a disjointed, disorganized circumstance at the first go-around anyhow.
Yeah, and so one of the things that we need to talk about a little bit is prospective payments versus retrospective reconciliation. So like the bundle payment that I signed in Virginia and then eventually turned into the ACE demo was prospective payment. Right now, the bundles that they're developing are retrospective reconciliation. So the good news is, and it was good, and I lobbied for this at CMS, is that you need to just pay the providers what their fee-for-service fee is, and then you need to look at the total episode of care and do retrospective reconciliation, and you have to assign somebody to be the accountable entity to either receive the bonus or to have to adjudicate the penalty. But that's a little bit easier because from a business standpoint, and Steve, that you'd rather just get paid instead of waiting till the end of the year to get paid a lump sum. So you just keep that income stream going and then do your retrospective reconciliation. So they sort of disbanded it. At some point, these bundles will be prospective, but at this point, I don't know. I've spent a lot of time talking about this and with CMS, and it's very difficult right now. I don't think they have the infrastructure to make it viable on a grand scale. They did it for the demo, but on a grand scale, it's a little bit rougher. I mean, it really is, because when you do the prospective payments, you need a third-party administrator to adjudicate all of the billing and how the money is distributed from the hospital to, say for your practice, you're independent within, Florida Hospital. Who gets the money? The hospital, and then you have to have subcontracts with them to get paid what you think is a fair payment, and so it gets pretty tough on a prospective model.
Yeah, and I think the other thing that you had shown, Dr. Rich, was the exclusions from the program. That was our biggest issue, is at what point the exclusion was identified. And I think that's moving forward into a new bundled program. I think that's one of the things that the STS or the cardiac surgeons need to really address with CMS, is how to identify and adjudicate the exclusions prior to putting these people in the programs.
Yeah, and like I said, I've been working with Acumen and CMS, and we had to define. We wanted to pick two procedures. It's very difficult, to sort of do this, and the two that we picked, because it was very heavily weighted on the committee towards cardiology, and I was the co-chair along with a cardiologist for this committee, which is still ongoing. We picked elective PCI and a STEMI with a PCI. And then surprisingly, everybody voted, and I voted a little bit for a window, a pre-op window or pre-procedure window. They wanted zero. They wanted zero responsibility for anything that happened before the procedure, even if it was an elective PCI. An elective PCI obviously has a stress test and a catheterization and things like that if it's done in a staged way, but it's still, that's what the cardiologists wanted. And they only wanted a 30-day post-op or post-procedure window. So there's a lot of resistance to the way CMS had put out the mandatory CABG bundle with the 30-day window up front and a 90-day window back on the backside with the responsibility for post-acute care. So we were going to have to go and be responsible for whatever financial stuff was happening and the research utilization in SNFs or IRBs or LTACs. And I don't know when the last time, Kevin, you were in an LTAC or an IRB or a SNF, but it's pretty rare that we would be walking out of our hospital and going to SNF to see our patients. So we have no idea. It's a big black box. And it was a bit of a surprise because when we did our bundle in Virginia, we actually included SNFs, but then when we converted it to the ACE demo, CMS truncated it. They cut it off. They says, the reason we're not going to allow that is because we have no idea what's going on there. Mm-hmm. We really can't, figure this out, and we wouldn't want to put you responsible for it. But then they added it into the mandatory CABG bundle, which is why there was a big uproar against it.
Good discussion. Do we have any other questions or kind of summary comments? We're coming to the top of the hour.
No, I appreciate everybody's time and just listening. I think there's a lot of moving parts here. I just want to make sure that everybody realized, how dangerous MIPs can be, and how we should, think about how we can move into alternative payment models and advanced alternative payment models, and how we should encourage CMS to either create them, or how we should let us create them for ourselves, so that they make sense. They make sense from a clinical standpoint, from a financial standpoint, because I think that it could be very dangerous if we're out there, competing against each other in MIPS, and somebody's going to win and somebody's going to lose, and you can't win every year, and it's going to be, it's just, I think very much like the SGR, except there's quality measures attached to it, and there's some other measures, some other domains that you saw, but I think it's going to be a challenge to to get away from that. I would recommend you do it as much as you can, and that's what the grant is about.
Okay, thank you so much. And for those of you who listened as a recording, if you've got questions after listening, please let any of us know. Dr. Rich, Eddie, myself, Ivan Burkle, Jana Eller will address your questions as best we can after the fact. Thanks, everyone. Have a good evening, and get all better down there in Florida.
Well,
Yeah,
thank
thank you.
That's very good meeting.
Yeah, Kevin and Steve, I hope things work out better.
Yeah, thanks. I tell you, we just can't hear this enough, Jeff, and as always, appreciate your time put into this. But yeah, we're doing better down here. We appreciate it.
Yeah, well, good. The
Got a
hospital
lot
is
of
doing.
notes and things, and I appreciate all the concern for us down here.
Yeah. No,